Welcome to the Bundled Payment Conference. Can you hear me? Can you hear me in the back? Yes. Okay. Many of you probably thought this was the Colorado Spring Ski Exposition, but this is indeed the Bundled Payment group that we've got together here, and we are really excited to have a wonderful group of speakers, and we have over 200 people here interested in something called bundled payments. So on behalf of CIVHC, I'm Phil Kalin, the CEO, and we want to welcome you here for what will hopefully be both some great learning that our three speakers will provide, but more importantly, we're looking for some dialogue here as we go along. So I was with a group last night, and I said, you know, and these are lay people, non-health. I said, we're doing a thing on bundled payments. And I could have said we were having a conference on racketeering and money laundering. You know, like bundled payments, what in the world are you talking about? And so for the layperson, they just say, you know, I have no idea what that is. And for many healthcare people, it's kind of this unicorn. Like, we've heard about bundled payments, but does it really exist? And we have three speakers who will indeed convince you that this exists, and in fact, the market is moving this way. So as you can see up here on the screen, our objectives today is to get into the background of bundled payments, talk about some of the initiatives going on both locally and nationally, and then we're going to get deep into the why and how of implementing bundled payments, which we think you'll enjoy. And then Bob Kirshner, where's Bob?
Right here.
Right there he is, over there. Who's hidden away? Bob Kirshner helped organize this. Our director of payment will help moderate a very good discussion. Everybody familiar with AAA? Who's not? If you don't know it, then you probably should have been over at the ski conference. So it's about better health, better quality, and lower costs. And the work at CIVHC, we are about value, and we talk a lot about AAA and how do we achieve that through the work of our organization and many organizations represented here. And as we think about it, beyond just the better health, better care, and lower costs, we talk a lot about where the market is moving, and at the top you see highly integrated delivery systems are coming together in big ways. It requires fully engaged consumers to be part of this, very vibrant integration with public health. And then, as you see over here, and this is work that CIVHC has been doing a lot of efforts on over the last several years, is we laid out a kind of a pathway to say, where do we need to go as a health system here in Colorado, health system writ large? And we laid out, said, over time, we have got to get to global payments. But when you're in an environment that's primarily fee-for-service, making that leap is a very big leap. And we have some systems moving there, others are moving along a pathway, and as we'll talk about, a bundled payment is a way to go along. And this just represents going all the way from your left, fee-for-service. We're starting to see some great work on care management fees, pay for performance. Colorado has got a great reputation for a patient-centered medical homework, our comprehensive primary care initiative, and moving on the way toward global payment. And we think bundled payment is a very, very big milestone that will be increasingly getting more market penetration here in Colorado. Most of you, and I'm not going to dwell a lot, there are a couple of different ways to look at bundled payments. On the left there, as you see, you can think about it as a bundle for a chronic disease. So if you have diabetes, a payer is paying on a per month fee or for across a year of services to a primary care provider. If you think about it on a procedural basis, on the right there, it is more of a lump sum for a particular procedure, and we're going to get very deep into that, payments, bringing together a bundle for both the different specialties, facilities, et cetera. So where we are in Colorado right now, we worked a lot. I think I saw Amy Downs from CIVHC, who gave us a lot of help as we were pulling together information on where are we in Colorado now. So essentially, where we are in the fully insured, we're at about 75% fee-for-service. non-fee-for-service around 25%. A big chunk of that is Kaiser here in Colorado, and a little bit less penetration on the self-insured side. And the self-insured is actually a little bit larger market share when you think of kind of a commercial population. So CIVHC has done a lot of work under the leadership of, I see Barbie Andorf here helping us move forward, Edie Sun, and now Bob working on this. And we had a task force together that did a lot of looking at bundled payments and picked out, based on market penetration, the number of procedures, where we think there are opportunities, picked out these 6 either procedures or chronic conditions as areas for us to focus on. And there's increasing interest in these, and we'll be hearing more about some of these as we go along. So coronary artery disease and asthma obviously are conditions, and then bundled procedures for the rest of them. So in Colorado, there are a plethora of different initiatives going on. In the world of bundled payment, one of our speakers, Deidre Baggett, had helped launch the ACE program at St. Joe, Exempla St. Joe, and is now consulting nationally. We've got pilots going on with our friends from Colorado Business Group on Health. Where are Donna and Bob and Lynn and that crew? Up toward the back, working along with Prometheus, HCI3 down in San Luis Valley, Colorado Springs, a variety of other Medicare, the Innovation Center pilots going on with the institutions that you can see listed below. So there's a lot of movement, and we think there's going to be a lot more forward motion. CIVHC, as we've talked about, is doing a lot of work trying to help convene, serve as a catalyst for moving toward this. You probably saw outside here a series of works that we've done, legal guides, background lessons, et cetera. On our website, you can find all of this material. And also, CIVHC, as you know, is the administrator for the All-Payer Claims Database. So we've got groups, hospitals, doctors coming to us as they're thinking about this, saying, boy, it would be nice to have some data. And we have here with us our APCD team led by Tracy Campbell. So with that, I'm going to ask Bob Kirshner from CIVHC to introduce our panelists, and we will get going, and hope everybody has an enjoyable morning. Thank you.
Thanks, Phil. So as I was driving in this morning, I was doing something I do every morning when I drive in. I'm listening to NPR, and a story about Fleetwood Mac comes on. They're touring again. And they talked about rumors and how most of you, a lot of you are my age group, so you probably know that Rumors was a fiasco. The band hated each other. Marriages were breaking up. They were at each other's throats. But through it all, they put the music first, and they created a masterpiece. Rumors is one of the greatest albums of all time, I think. And I listened to it on Rhapsody purposely coming into this talk. So my point of this is, it made me think about the healthcare system and where we're at today. You have payers and providers, hospital, large systems at each other's throats and fighting for market share and fighting for everything that they can get. And it's a difficult time. Yet through it, there are slices of genius and slices of masterpieces that are coming through. You're going to get a chance to talk with 3 people today who have created what I think are masterpieces within this healthcare system that is coming apart at the seams. And I truly believe that the efforts that they're putting through can lay the groundwork for where the system needs to go moving forward to help begin the process of healing of our healthcare system. So with that, I'll introduce, we have Matt Flora, who is a supervisor of medical informatics from Arkansas Blue Cross Blue Shield. Arkansas has done some amazing things in getting a bundled program going. We have Deirdre Baggett, who I was fortunate to hear speak at the Pay for Performance conference in San Francisco a couple months ago. Deirdre is going to be talking about care redesign and how that's the linchpin for building a bundled product. Matt will be talking about the initial steps of data analytics that are necessary to get a bundled process going. And finally, we have Ruth Coleman from Cleveland, Ohio, and she's the CEO and founder of Health Design Plus, and they have created a bundled product partnering with centers of excellence around the country that is incredibly innovative. And I think the thing that all of these efforts combine is, just like Fleetwood Mac put the music first and put their differences beside them, every one of these plans puts the patient first. To create a bundled product and to really strive for quality, you have to put the patient first and not worry about how you're going to get paid, but worry about the best quality experience for the patient. And through that, you can have excellence and great outcomes and eventually lower cost. So with that, I'd like to start out introducing Matt. Oops, sorry.
Can everybody hear me okay through the mic? Well, I appreciate you guys having me down, or having me up here in Denver. I'm about a mile higher than I'm usually accustomed to this time of year, so a little something different's nice. In Arkansas, I'll kind of give you a little background on where we came from. About a year and a half, 2 years ago, our Arkansas Medicaid system was looking at a projected around $250 million shortfall for 2014. And they wanted to remain solvent. They didn't want to hand it over to managed care and things like that. So the governor and our director of Medicaid approached the executives at Arkansas Blue Cross, because we have the largest share of commercial business within the state of Arkansas. And they basically wanted to know, where do our incentives align in trying to get some control on the variation we see in the growing cost of health care in the state. So the outcome of that has been the Arkansas Payment Improvement Initiative. And it's basically a two-wave approach. Wave one is an episode payment model to kind of focus on specialist services and acute care surrounding those. And then wave two is going to be a patient-centered medical home statewide model. We're also one of the CPCI pilot states with CMS, so we're working on that as well. But today I'm specifically going to talk about what we at Blue Cross have had to do to make sure we've had an effective implementation of our episode bundled payments. Our overall goals in this, obviously, we want to improve the health of the population, but we have to make sure we've got a high-quality patient experience, access, reliability, and we've got to keep costs under control. We've got very independent delivery system. We don't have integrated facilities with all of their specialists employed. Our cardiologists are typically employed, but say our orthopedic surgeons are all independent. So with such a diverse delivery system, we had to come up with something that the payer has to take control rather than expecting the delivery system to be able to handle the bundle model. We want to improve care overall, not just save the money, and we want to make sure all the medical decision-making stays within the provider community and we don't have the payers dictating what level of care needs to be provided. In these models, the common theme is that we expect the payers to maintain all the actuarial risk. So if someone gets hit by a bus, we pay for that person. What we're trying to measure is, what are the different ways to manage that patient in their rehabilitation? To date, we have done some preliminary reporting on 3 episodes: perinatal, total hip, total knee replacement, and a congestive heart failure acute exacerbation inpatient admission plus 30 days episode. We started reporting back in July, and they went live January of this year, so services within the state count. This is not an opt-in model. If someone wants to accept payment from Arkansas Blue Cross or from Arkansas Medicaid, then they must participate in these bundled payment initiatives. Later this year, we're planning on rolling out some reporting for cholecystectomy, tonsillectomy, colonoscopy, a neonatal episode, COPD and asthma exacerbation established similarly to the CHF, and then CABG and stents. The main aspect of our model is we continue to pay our claims fee for service. Like I said, with such a dispersed delivery system that's not integrated, we have to make sure all the ancillary individual providers get their fee for service payments. Then at the end of a reporting period, typically a year long, we will aggregate all the claims related to these conditions or these treatments to do a retrospective settlement based upon that aggregate. The primary source of all this information is the claims data that comes from the payers. Whenever possible, we try to get everything we can out of the claims, but not everything's coded. So we've also built an online portal where providers can go and self-report some quality measures, because the quality measures are the key aspect to this from our perspective. And I'll kind of show some examples of that here in a few minutes. So this is basically what we have to show whenever we're trying to explain the reasons that we're going after some of these things. This is actually taken from, kind of taking a few examples out of it, but this is pretty representative of our total knee and total hip replacement episode, where each bar represents an orthopedic surgeon. And this is their average cost within a year, and I've changed the numbers, so don't think that we only pay $10,000 for an entire episode for a knee and hip replacement. But you can basically see that the low end spectrum versus the high end of the spectrum, we've got double. And we've risk adjusted these. We've gotten rid of extreme cases through exclusions and things like that. So from our perspective, we don't see any clear evidence as to why this variation exists. And whenever our self-funded employer group sees something like this, the very first thing they say is, if this level of variation existed anywhere else in my business, that would be my top priority to fix. So as a commercial payer, we felt it was our obligation to our customers to really understand where the reasons for this variation and get it under control. So what we've done in our retrospective model, once we've gathered our year's worth of data, we determine the average cost, and we set an acceptable amount, which is this, I believe, red line here. Any provider whose average cost is above that amount is responsible for sharing half of that distance with the payer for their case volume. So say this is around 7,200, and that's 10,000, so we've got 2,800 there. They're responsible for sharing $1,400 per case back with the payer. Anyone between these two bars, the acceptable and commendable line is what we call this, will see no change whatsoever. They get no risk sharing, no gain sharing, it's just everything is normal. And then below commendable, these down here, all get half this distance paid out for their case volume as a gain sharing reward, so a bonus payment. And then we want to ensure that no one tries to game the system and withhold care from their patients, so we've set a floor on that so that providers don't have an incentive to continually push that cost down below a level that the patients would need in order to maintain their quality of life. We publish all of these prospectively. We'll look at 2 years of historical data in the state of Arkansas and say, how are you performing today? Our actuaries then look at that, they see how fee schedules are going to adjust over time, and they're going to say, in 2013, we're going to have this acceptable, this commendable, and this gain sharing limit, so that you know 3 to 6 months before 2013, what you're shooting for. So if you're already in the red, you get historical performance reports so that you're aware of where you stand, and then you can say, this is what I have to do to get down, so that potentially everyone could win. The providers can get out of the red or into the green, and the payers basically get the reward of having lower or reduced overall claims costs as long as the quality has been met. Another caveat is, if you fall below this cost bar here for acceptable, in order to receive those bonus payments, you must meet some minimum standards for quality measurements. Right now, we've kind of set those as you've got to be a solid B. We don't expect you to be an A student since it's an early prospect right now. But we want you to have some level of quality as compared to your peers in order to get those gain sharing payments. The general process, we identify potential episodes based on prevalence in the market. We've looked at different episode definitions. We look at the open source Prometheus models. We looked at Optum Insight's ETG grouper, and there's a lot of gaps in those that didn't quite fit in our delivery system. So some of ours had to go straight into manual definition based on clinical interviews with providers in the state and medical directors for the payers. So we've got kind of a hybrid approach in the way we build our episodes, custom tailored to the Arkansas market. Once we've got an idea of the general approach we're going to use, we'll select between 3 and 10 champions within those specialties around the state for kind of private meetings to say, here's what we're thinking about doing, here's the variation we see, here's the general model, what do you think about it? And so for the neonatal episode, we've got neonatologists, facility administrators, and everybody around the state, kind of some key personnel to say, this is what you need to do to make sure the providers are protected and the patients still receive adequate care within these episode models. Throughout each of this, the payers have to represent basically that same distribution to say, here's what the cost is. Okay, now we're going to apply this risk adjustment. Here's what the cost is. This is what we see for the quality measures right now. Is that acceptable? So we share all of these at each step of the process. Once we've gotten that, we use those clinical advisors, is what we call them, to determine what are our exclusions, what patients are so extreme that they should be excluded from this process entirely, what are the appropriate risk factors. So if you've got a patient who needs an extra $10,000 worth of care, we remove that from your episode costs so that it looks more like a standard episode and you're not responsible for the more severe cases. That way you don't have an incentive to cherry pick the healthiest patients. You almost have an incentive to work on the higher risk patients because those risk adjustments will kind of neutralize that. We discuss who is the principal accountable provider. Under our model for, say, knee and hip replacement, the orthopedic surgeon is accountable for that episode. So they're responsible for the workup prior to the surgery itself, the facility it was performed in, and the delivery of, or basically what they order for the physical therapy, and any readmissions or complications that might occur. So that one provider, even though they don't see all those fees in the fee-for-service model, they're accountable for all those costs. So we have to have conversations with the delivery system and say, was the orthopedic surgeon the best person to pick? Do they have full control over what's ordered, where things are performed, and all the decision-making that went along with that episode? If not, then we have to determine someone else. Congestive heart failure, the facility is the principal accountable provider. For neonatal, there's a lot that goes on between the physician and the facility, and some of it's outside of control of the other. So we're looking at a shared accountability model for that, and we haven't really decided what route we're going to go yet. We're still in conversations with our clinical advisors in that area. Then we look at the granular level of, okay, what procedures belong within the episode costs, what drugs belong within the episode cost, what should be excluded, how long do we look prior to the trigger procedure, how long do we look after the trigger procedure, and we fine-tune that episode model with our clinical advisors. Once we have that, so we consider it a 90% complete episode, we'll have a town hall where we'll invite everyone that we feel could be affected within the delivery system in the state. We set those up at our University Medical Center in Little Rock, and they've got remote facilities around the state with kind of teleconferencing sites set up so that everybody can see and participate in those conversations and see kind of the 90% view of that episode and provide feedback that we may not have gotten from our clinical advisors. We also have our clinical advisors on the podium with us to kind of help explain how we got from nowhere to where we were at that point in time, so that it's more of a peer-to-peer conversation and not just the health plan saying, this is what we're going to do. We try to have clinical input involved throughout the entire point of the process. And Arkansas Blue Cross, a smaller private payer, Qual Choice of Arkansas, and the state Medicaid agency stand together at these public work groups and present our own data so that the delivery system can see what each payer has at stake. Once we have that feedback, the payers kind of align on the general clinical principles of the model, what should be considered for risk adjustment, what should be excluded, what is the core definition of the episode. And at that point, the payers kind of go to their separate rooms and determine, well, what do we capture in our claims? How can we price this within our own population and develop our own thresholds so that we can kind of make sure we're not violating any antitrust by aligning on the pricing models. We then have to amend our provider contracts and build out preliminary reports to make the providers aware of where they stand under that model today, so that in 6 months when it goes live, they have had time to kind of adjust their practice to get to where they want to be. Throughout this whole thing, we have to share extreme volumes of data with everybody that asks for it. We've got to have, all the payers have built pretty intuitive data warehouses where our analysts can basically run our numbers and kind of cross-tab it however we want to say, okay, when we apply this adjustment, this is what happens. If we've got this new quality metric that we need to add these 3 procedure codes to, this is what happens to the state averages. It's because we've got to be able to share these in a pretty quick turnaround. I think I started on the project in early April of 2012, and we went through this process and had our first set of preliminary reports in July of last year. So it's a pretty quick turnaround, and you've got to have the infrastructure to set that up. And that's for the claim side. Here's just a screenshot of what our provider portal looks like for congestive heart failure. So you can see the provider can go in, select what payer this patient belonged to, identify themselves, identify their patient, and then say, what were the results of the left ventricular ejection fraction assessment? What was the value? Did you prescribe ACE inhibitor or ARB therapy? Why or why not? So that we can kind of track some core quality measures within these that aren't necessarily available in the claims data. Kind of the basic principles of it, like I've talked about before. We assess our cost and quality annually. We'll settle for the gain and loss sharing at that time. So we're going to look at our first settlements based on the 2013 year and 2014, probably around April to June, somewhere in there. Throughout that year, we're going to have quarterly reports so you can kind of see how you're progressing along that time. So if you're high in the first quarter, you've got time to get that back under control before the final settlement occurs. You can pick those reports up at the same portal where you make your data entry, so it's one stop. All 3 payers use it, so providers only have to go to one place. And all the payers provide code-specific drill down. So here is the basic PDF or provider will get. It says, in general, you met your quality of service, your average episode cost was commendable, so you'll receive gain sharing of around $2,500. Here you get a little more detail for that episode. You can see where you are, the state average in that range of acceptable, commendable. Down here you get a similar thing where you can say here you are as a percentile within the state, so you can see how that really is distributed. They've got, you can see the episode distribution, so if you had one high-cost episode that was driving you up, you could kind of fine-tune that and determine what it was. We compare you to the state, and you can see where you stand on all the quality measures, comparing you to the state averages. And these lines represent the minimum thresholds for those. Then we have subsequent pages that go into a little more detail for people who are more number-oriented and want to see percentiles on their quality measures, which nobody really wants to. But you can see where you are compared to the 25th percentile in the state. So chlamydia screening, 25% of our providers have a rate below 1/3. That's one of our biggest wins. A lot of people kind of just said, well, I know my patients, I don't have to do that. So we've had to kind of have those conversations with some of our rural physicians and say, no, the medical literature says you need to do this for everybody. So we've had some pretty big wins already just in this level of transparency. Then they can get into a little more detail on the cost, so you can see what side of service is driving your episode cost. And then say here outpatient surgery is higher than the state average. So we can provide drill down and say, these are the services you're providing at a higher rate than everyone else. Why are you doing that? If it's justifiable, maybe we need to adjust our model. If it's not justifiable, then it's time for you to reflect on kind of some of your practice methods. And we can do all of that drill down as requested for any of our providers as they go through these. We go on site with a lot of our facilities to explain these reports. We bring our drill down with us so that we kind of hold the hand of both the physician and their office staff, because their office staff are the ones that actually deal with this day to day. So it's been a lot of feet on the ground, a lot of hand-holding with an analyst who understands the data, a medical director who can have the peer-to-peer conversation, our network people that can talk on the business side, and we've also set up a provider customer support line that goes directly to my analytical staff. They don't have to go through the regular customer service channels if anybody has a question about their report or the program in general. So that real-time answers to their questions. Our goal is to eventually have an online portal where you can kind of go in and drill on the data yourself, and we're still trying to figure out the best way to do that because we don't have an all-payer database in the state of Arkansas. So getting alignment from independent payers has been a bit of a challenge in these early stages. But here are the results based on the historical performance, where you can kind of see we had 228 perinatal doctors identified. You have to have 5 episodes to be involved. We don't want one extreme case to get through our adjustments and exclusions and throw you out or make you have to be in that not acceptable amount. So we kind of neutralize that with a minimum of 5 limit. That brought us down to 161 providers. 44 were eligible for gain sharing. 23 were eligible after we applied the quality metrics, so that chlamydia screening was a pretty big deal for about 21 providers in our state. Loss sharing was 32 providers. The max gain sharing payment was $12,000. Max loss sharing was $19,000. This was historical. We've since looked at some more recent data, and we've really seen a shift. We do have a couple of providers still in the red, but what was almost a revenue neutral model to begin with has become almost 4-to-1 gain sharing to risk sharing. So a lot of people are starting to move down in the curve, which is good overall for the payer, because even though we're paying out that 50% in gain sharing, we still saved 50% of that in the reduction in claims cost. So both sides are winning already. Basically, you can't spend enough time on education. You've got to get out there in the provider community. Payers have to be willing to explain the model, explain the data, and talk about these things with the individual physicians to get a good understanding of how these episodes were developed. And the data will surprise you, and typically not in a good way. There's always going to be something that you didn't expect. You're going to have something in your payment system that you weren't aware of at the time because you've never had to look at it before. And it's a new level of transparency. We've had physicians that really didn't think about the fact that they ordered continuous passive motion devices on all of their knee and hip replacement patients just because they had a good relationship with their DME supplier. And now they have a little bit more transparency to say, you know, you're the only one in the state doing that, maybe you should reconsider. So it's had a lot of interesting conversations, and I think it's been pretty good so far in the state of Arkansas. So I think that's pretty much the broad overview. Did we have a few minutes for questions, or do we want to?
We're going to hold questions till the
Okay.
end.
That's not you. There you go. So I've actually heard one of another colleague from Arkansas do this presentation, and one thing that I think is really important as you heard that what's going on in Arkansas is that when you look at how they defined readmissions and sort of the readmission and inclusions and exclusions, they actually use the Medicare Bundle Payment for Care Improvement Initiative readmission definitions, which are not my favorite, but But, we often say, as goes Medicare, so goes healthcare. So I think, obviously there are many things that are different, but there are certain things that you guys absolutely modeled after Medicare. So I think that's important. So what I'm going to talk today about is the care redesign piece. My work in bundle payment began in the summer of 2008. My husband and I had moved here from the University of Michigan. I spent most of my first 10 years of my career in academic healthcare before coming to Exempla St. Joe's in Denver. So I was running the cardiovascular program there, where our CEO had suggested that we apply for the ACE demonstration project, which we did, and I'll talk a little bit about that. More recently, beginning last summer, I began doing some work for CMS and served as a reviewer for the Bundle Payment for Care Improvement Initiative, and then also do some work with their learning forum. So I also, as we go along, will talk a little bit about the time I spend with CMS and what I'm seeing there. So when we began down the path with the ACE demonstration, the truth of the matter is we were looking to grow market share. We saw that as a potential opportunity. With ACE, there was exclusivity, and there were some other features of that study that we thought might steer patients to us. And I remember the very first call we got on with all of the ACE sites, pretty much we all said the same thing. We thought that, this would be a volume play. And so, just to sort of disclose that up front, what we learned pretty quickly when we got into this was, we really didn't know what we were getting ourselves into. The reason I do the work I do today is because I think it's the only thing I've done in my career that really transformed the relationship between clinicians and leaders. And so before we ever went live with this project, whether we got another patient or not, we were beginning to do things that sort of we'd always wanted to do, but didn't really have the right incentive to do so. So we began to have conversations with our providers that we'd never been able to have before. So, and really at the end of the day, it was really around care redesign. So I'm going to talk a little bit about exactly what that is. You read a lot in your journals and literature about sort of new care models and from the perspective of really what it took for us to be successful with ACE, both in terms of improved quality and reduced cost, as well as the work I do around the country. Probably most interesting work I do right now is in Boston with a couple of the large payers, Tufts and Harvard Pilgrim. But it's very similar work on the commercial side as well around care redesign. So in terms of the elements of care redesign, so obviously the guiding principle is around increasing value of the services provided. Beginning with the end in mind, clearly defined deliverables. I find that when we sit down with physicians around this work initially, they have a perception that we're really just focused on reducing cost. And people ask me all the time, with ACE or with bundled payments, is it about less care or reduced care, or we somehow erode the art of medicine? From my perspective, I thought it was about the right care. I think we moved away from sort of the shotgun approach to everyone is on fall restrictions or everybody needs to go to the Coumadin clinic to actually what is the right care for the right patient. I think really at the heart of it for us was really around being willing to upend the status quo. When I do work, I was in Boston 2 days ago with a physician group, and they really were stuck in sort of, the comfort of where they're at today. And so I think if you're not willing to, challenge the status quo, this work becomes very heavy work. Innovative, what we did when we started this project, sort of getting ready for ACE, was we began to do what I think other industries do much better than healthcare, is we began to bring other people to the table beyond, the sort of typical roles in a multidisciplinary team. So we began to bring, engineers to the table and other specialists within the health system that didn't typically come to the table when you think about care redesign. So we really wanted to innovate. This wasn't, teetering at the edges. This is really about transformation. A lot of creativity and courage, and this is where you need executive level support. We did some things that were very different from how we had typically and traditionally provided care to cardiology patients. And we did it very rapidly. So this wasn't about incremental change. And so you have to have senior leadership support to be able to do rapid cycle change, and that's not about sort of incremental efforts. It's rigorous. I think this is the hardest work I've done in my career. I started as a nurse and then went into leadership, and we were about to implement EPIC at the same time, and I thought this was much harder. And the reason it's much harder is I think that, we're great as clinicians at doing more for patients, and we're not quite sure what's wrong with the patient, so let's do more. I think it's the doing less and sort of only giving the patient exactly what they need is really difficult. Giving them not what they need is something that we're not good at. And so I think that's where our team really struggled to be committed to the evidence and committed to, you talked about the chlamydia screen. When I, started my career as a nurse at Northwestern, I didn't know what was going on with the patient. Okay, so let's do blood cultures or X-ray or EKG. We had to stop that, and we had to really commit ourselves to the evidence, and I think that was the difficult, challenging, sort of rigorous part of all of this for us. The other thing is we had to include patients and families, and I know we're all moving to that as a country. The work that I do with Medicare right now, I would say of the 464 sites that applied to participate in the Medicare pilots, in the Model 1, so Models 2 through 4, only some sites did interviews. In the Model 1 interviews, there was only one site that had a patient in the interview process. So truly having patients and families embedded in your care redesign and having an equal voice at the table just enables a level of innovation and change that is not something that we historically had achieved by just sort of ad hoc kind of in name only representation. Planning and managing for internal resistance, I think what Exempla does really well is performance improvement and quality. And so we had a plan, very systematic plan for how we were going to manage resistance, what we thought our risk points were. And I continue to do that work on the commercial side with commercial payers and hospitals, but really expecting the resistance, planning for the resistance, acknowledging it on your timeline, and allowing time for people to voice their concerns and having a forum to talk about what they're afraid of and what they're what's uncomfortable, but to not plan for it really puts your project at risk. Obviously, change it is measurable, and I think, not overwhelm. What we did at St. Joe's with the help of our corporate folks is we just committed to 25 metrics for this initiative, no more, and we started with 150. So I think, the other thing that I think we did well, and I continue to do in this work, is really trying to keep it simple. The bundles of the 90s, were very simple. I think they're getting more complex when you look at post-acute care and readmission. But I think as you move into this space, trying to keep it simple, measurable, something that's doable, scope and scale, and managing that are really, really important. I talked about evidence and collaboration. We started this with ACE, and I continue to only do this work this way. But I think we, historically, when physicians aren't able to come to meetings, we go ahead and have the meeting, and we may or may not in the hallway update them. But we'll go ahead with the meeting. In care redesign, when you're talking about changing practice and changing protocols, you have to have 100% of the providers at the table. And, on occasion, can you meet with the provider, after the fact, maybe okay a little bit. But what we found with, getting ready for ACE was we couldn't make decisions with, if we're talking about EP or talking about cardiology, and we're going to do something different in terms of how we manage a patient. You have to have all the providers at the table. And one of the things that we heard a lot from our providers was, well, if you really value this work, you'll compensate me for it. And I personally struggled with that a bit because I thought, well, this is the right thing to do. We should all do this. But ultimately, we compensated them for their time. And I absolutely think that was the right thing to do. We had 100% attendance. We were able to move. Having 50% attendance, I don't think we would have actually been able to do work that was truly transformative. And then the other thing, I think, giving up swim lanes, it's sort of the traditional silos in healthcare, and really having more of a sort of flat structure where everyone's voice is equal. I think we've already heard about transparency, but the level of transparency that we got to, I can tell you, was for sure uncomfortable for me at the outset, sharing with our providers exactly how hospitals are paid. Was uncomfortable initially, and then then we moved to sharing supply cost data, and then we moved to sharing and unblinding all of our clinical outcomes and cost outcomes by provider. But I think as important probably as the financial incentive for physicians in terms of really rapid change, I think the transparency is probably almost as equally important. In terms of the framework for care redesign, clearly defining the population, I think where this has been best studied in most studies, obviously in high-end elective procedures. What we're seeing with commercial payers is they often start there as well. I think in my work with the Medicare applications, mostly what I saw was cardiac and orthopedics, a little bit of heart failure, a little bit of spine, but certainly defining what is the population that you are going to redesign care for, and ensuring that there's enough volume and enough upside and benefit, to do this work or to start this work at least, in an organization on a smaller population. It's such heavy lifting. In the work that I do, we really try to look for a population where you can really affect change, and then you certainly can scale that to other areas of the organization. In terms of the team level setting related to cost and quality, I think we spend a lot of time today educating physicians around how hospitals work, and having physicians understand what contribution margin means versus profit margin. They really appreciate it at the end. I think early on with ACE, I had a physician say to me, phenomenal heart failure, always gets 5280 Physician of the Year. He said, Deirdre, I didn't go to medical school to worry about readmission. If the patient doesn't weigh themselves, the patient doesn't take their LASIK, it's not my problem. And so really paying, time to helping physicians understand how, in today's world, we are responsible for managing cost and educating them so that they can actually help influence reducing cost. What I found was our physicians had much more insight into reducing cost and reducing variation than we ever had. Obviously, value-driven and measurable, we've talked about that. Really committing to a roadmap and timeline. I think what bundled payment, I talk sometimes about the risk with bundling, obviously not resourcing it, but also not really understanding the scope and committing to a roadmap and timeline. You get into this work and you realize, the program sort of grows as you start to identify gaps in your system and gaps in your processes. So very committed to a timeline, where you're going, what your roadmap is, and what your outcomes are. We use a lot of lean work with ACE and continue almost everywhere I go. There's some sort of process improvement methodology, whichever one you use and are committed to. And we've had to do a lot of education with physicians around that and continue to do that work. Prioritizing the opportunities and really staying committed to that. And then the obvious ultimate outcome for us with ACE was 5 protocols by subspecialty. And obviously evaluation and then implementation and how we're going to sustain it. This is a sample structure, so this is actually for a Medicare bundle, but this gives you an idea of the major buckets of work. Obviously, the finance and actuarial work are oftentimes new work for, particularly for hospital types, and even for some of the health plans that we work with. What I find is a lot of variation around the country with respect to health plans' ability to actually do this work. Obviously, I think the care redesign, is a huge risk factor. We've seen programs who, Ohio State, I think, is a great example in the last round of bundles where if you just give a discount or you just sign a contract and you do nothing in terms of care redesign, probably not going to be successful. And obviously, if you're doing any work around accountable care, making sure that this work is really connected and you're leveraging synergies across both of those bodies of work. There are a lot of contracts and legal implications. Obviously, when you're talking about physician bonusing and pay for performance, new work around sort of some of the legal aspects of this. This is a sample project plan, and for anyone who wants these slides, give me your card and I'll email them to you. But the point here is that this absolutely has to be resourced. You have to have a dedicated, committed team to this. This is very complicated. Some of the analytics around cost, as well as really understanding where your true opportunities are. It's a significant body of work, and that really needs to be resourced. I won't spend too much time on this, but this is really the work that we do with physicians. So we really try to be efficient with their time. So when we do some of the lean work, we really bring that to them and not have them in all-day meetings. And we validate sort of, is this really, what you experience as a current state? And nearly every place I go, and it's no different from us with preparing for ACE, even within a 20-member cardiology group, you've got 20 guys practicing 20 different ways, and they don't even know it. So, sort of understanding really where you're at today, where you're headed, and letting your physicians help drive the priorities. This is a sample prioritization matrix. And then this is a sample of, we start with sort of blinded data with physicians when we begin to talk about cost and length of stay, and then ultimately get to where the physicians are absolutely comfortable with looking at their data compared to their peers. And what I really loved about our preparation for the ACE demonstration project, I knew we were on path when at one of our physician steering committees, we got stuck on these providers asking each other what they're doing, how are you getting this outcome? And it was sort of, for me, it was almost like nirvana that they were actually, talking about best practices amongst each other based on looking at data and internal benchmarks. This was another big body of work, and I think with ACE, this was really the low-hanging fruit. I think it, obviously gets harder over time after you address some of the low-hanging fruit around vendors and supplies. And with, bundles that are medical bundles, obviously, they're much more challenging because, you don't have this opportunity. But we had to be willing to go to our vendors and say, we're going to share data, we're going to, we want transparency around our costs, and we have to be able to share that with our providers. And what we found is our providers, thought they knew what things cost, and they thought they understood by vendor, what was going on, and they really didn't. And so being able to pull this data and share this data with the providers is critical to affecting change. This is a sample commercial bundle and sort of kind of how the commercial bundles work. Typically, you're sort of comparing to the market, and this is some of the work that we're doing in Boston. But what happens on the commercial side, I think, obviously having access to good data on the market and then comparing the hospital and providers to the market, and then sort of breaking out the various aspects of the spend, and then which ultimately drives to a proposed price. So this is hips and knees. And this ultimately, is basically what a sample commercial episode looks like, and it doesn't look a whole lot different from the Arkansas episodes, but starts out very, very, long and complicated, and gets to what's in and what's out, and then what are the readmissions that we're going to take risk for. So this is a result of really a lot of analytics. So I will stop there.
Good morning. Oh, come on, you can get a little more energy. Good morning. Great. I'm Ruth Coleman, and I am founder and CEO of Health Design Plus, a company that you have probably never heard of before. I will tell you that our clients call us the Navy SEALs of Centers of Excellence. Walmart actually coined that. And basically they say, if you hear Centers of Excellence, you won't hear them, you won't see them, but count on it, they're there. So my biggest concern is the Navy SEALs tend to leave body bags behind them, and that's not what we're trying to accomplish here. It is really fascinating to hear what Deidre and Matt are doing. I'm going to share with you a little bit different today, and I'm going to ask you to try and do a little bit of a paradigm shift because I am a nurse. I practiced and taught nursing. I've been in hospital senior management, and then I went to the dark side, to the payer side, and then started the company as a care management company. And we've stayed very true to our roots, and it's still. It's amazing to me as we go out and we negotiate contracts and we work with providers how much the thought process is ingrained in what the payer side has insisted on for years and years and years. So I think to be able to be successful in this kind of venture, you really need to think differently, and we work very hard with our providers that we're contracted with to make that happen. So one of our premise around bundle pricing, we've been in some sessions with some of the policy wonks from DC, and they really see bundle pricing as a price play. It's payment reform, and that's what it is. And that was kind of an aha because that's not how we see it. We see bundle pricing as a platform to create buyer and seller partnerships, and it has real value in the long run on how it becomes that platform and how it moves people towards quality rather than just price. We call this program our CliniFit program, and it's kind of a combination of clinical and benefit. And that's really very much what this is. It's a very clinical-driven program that happens to be sitting on a benefit platform. At this point, we are doing predominantly high-cost surgeries that we're traveling across the United States, and we're doing heart, spine, and joint replacements currently. We have some programs in pilot or that we're developing around medical conditions, so it's really interesting to hear what Matt and Deidre are doing that because it is much more complicated. Pushing the wrong button. Currently, we have through large self-funded employers, about 2 million members that have access to this program or one of these programs. We are currently working with multiple employer groups, several of them, to make this available in a couple ways. One is to make it available to smaller companies, because generally if you want to do this, the model as we're doing it as a standalone, we say if you're less than 20,000 employees, you're not going to get an ROI out of it. But we've been challenged with how do we take this to our good clients, our good TPA clients, that have 8, 5, 10,000 employees in their population, and they're dying to do this. And we've found that we really have to work with employer aggregators. And we have one we're working with right now that's a very large employers, another one that's kind of regional, that's large and smaller employers, all self-funded. And then one that's a platform on a different product, but they want to expand the product into centers of excellence. So in 2014, very early, if not 1/1, very early in 2014, we will be adding about another 5 million folks that have this program available. Kathleen Bartholomew did a very interesting web article last week, and it was like, oh my gosh, this just says it all. And I can certainly get you the link. I've gotten the article to Bob also to share it. But basically, what she's talking about is revolution. Now, I don't see what we're doing as revolution, but some people do. And that how revolution starts as a small idea and people talking and doing the kinds of collaboration that these folks are working on, which is part of the paradigm shift. And then in 2012, Walmart then announced that they were going to do foot 100% of the benefit, all travel costs for a member and companion, with 6 facilities in the United States that include hearts, spines, and transplants. And we're moving forward into other areas now. But it was very interesting because she said, why are employers driven to do this? And basically, she said it was because of the quality varies so greatly between hospitals, between regions of the country. I can tell you these jumbo employers just are crazed about why do you pay a price here in Denver and you pay half or double the price in Texas. This makes no sense. I mean, these are large employers who have manufacturing, who have retail, who have it all down, and they don't understand why as an industry we don't. And it's getting more and more difficult to be able to explain that. Not that it was ever easy, but it's more difficult now. Her comment, which I think is interesting, she's also a nurse, but that hospitals remain oblivious to the fact that even they perform unnecessary operations. And I'm going to talk about some of our experience just in 2013 in a few minutes. But I can remember when I was a hospital VP and I was responsible for quality for risk, as well as a number of different areas throughout the hospital. We really did very little of asking, how many unnecessary joint replacements are we doing? How many unnecessary heart surgeries are we doing? We didn't want to ask those questions because having people in those beds is what kept us going. So it is really, we find a lot of folks in the hospital world really don't understand how much unnecessary work is being done. They can't, because if they did, we wouldn't be seeing what we're doing now. And there was a recent article in JAMA in 2012 about who benefits from medical errors. And it's very interesting, and basically they said the hospital benefits by about $39,000 on average per case for errors. If there was ever an upside-down incentive system, that would be it. And then I've had people ask me, okay, and from all over the country, how do we get prepared to be one of your centers of excellence? And she just said it. It was terrific. She says utilize a team approach, appropriately select treatment, have at least some above average quality metrics, and be, more importantly, measuring and have a process for communicating that to internally. Make sure that your incentives are aligned, and you both have been talking about that. It's terrific. When they say incentives, it's the employer or payer and the patient, or I'm sorry, the hospital, but it also now includes the patient, and it includes the physician team, and the other team. It's not just, this is not totally a physician-driven model. And then transparency. And we happen to believe that part of the value of bundle payments is it makes a lot more transparency available, both to yourselves if you're in a medical delivery system, but also to the employers and, frankly, employees. And if you don't know it, there are companies out there that are growing very rapidly with transparency tools on the web, where they've got a lot of data and they're telling the members, particularly they're focused highly on the CDHP members, but they're telling the members, here's who has what kind of quality, and here's the price. And if you're not aware of that, you need to be. So our evolution in 2010, we got into this, and we've been doing direct contracting since 1988. We've built centers of excellence for clients. But this kind of new model, we went live in 2010 with Lowe's, the Lowe's Cleveland Clinic program that got a lot of publicity around the country. And that was a predominantly heart surgery program. We've expanded it now a bit. But that's what we started in 2010 with that program, added several other large employers, some of which I have no permission, I cannot say their names, but two that you would recognize as PepsiCo and Boeing. But they were single center models where we would just fly people. I was telling folks last night, our patient number 3 in the Lowe's program, we flew from Wasilla, Alaska, And no, he didn't see Russia from his porch. But Wasilla, Alaska to Cleveland Clinic for, amazingly, a elective 4-vessel cabbage. He came in, had 2 days pre-op, had a surgery, went home within a week of the surgery, and has done amazingly well. I mean, it was, even for somebody who's been doing this for a lot of years, it was totally amazing to see an elective cabbage from Wasilla, Alaska, go home and do fine. And then in 2014, what we're doing now, because obviously we're working on the 2014 benefit year, these large employers, if they're going to, and one of the things that's nice about this program is you don't have to do it on benefit year. But most of them want to do that because that's their primary communication model with their associates. So we're working on adding more regional centers. Oh, sorry, 2013. That was a big year. I missed it. We started working mid-year last year with Walmart to create the program. We ended up with both Hearts and Spines. At Geisinger, Cleveland Clinic, Scott and White in Texas, Mercy Springfield in Missouri that has a dynamite. They tell me I'm not allowed to tell people this, so I'm whispering. They have a dynamite spine program there. I think it's the best I've seen in the country. And goes to the focus factory idea. And then Virginia Mason, many of these are names that you would know. And then transplants. Walmart has actually had an exclusive relationship with Mayo for transplants since 1996. So what we're looking at is we're adding regional centers, we're adding employers, a lot of employers. We're adding conditions, some of which is surgical and some of which are medical. And we're looking for focus factories. We're looking for hospitals that have the courage, and I was so glad to hear you use that word, we talk about it all the time, that have the courage to say we are going to excel in a limited number of things, and we're going to put our effort at excelling nationally in a number of different things, in a couple different areas. So our criteria, although Kathleen Bartholomew's article really lays it out, we want to see that there's already demonstrated quality through published outcomes. We don't want to be working with folks at this point who are saying, oh yeah, we will publish our outcomes. So if you want to get prepared for this, begin to work on that and you haven't, or worked with registries or whatever, that is just very, very important. We're looking for indications that they're practicing evidence-based medicine. We're looking for a quality-driven management process. I've got the opportunity to sit in on one of the Tuesday sessions with Virginia Mason. They blew me away. Absolutely blew me away. And when I look at what our clients, employer clients are doing in retail, and it's the same thing. They've adopted the models. They send their new managers to Toyota in Japan to be trained in lean. It's pretty amazing. And then peer review, shared decision-making, and willing to work as a collaborative and as a partner. And that's not just with us and the employers. When we put the regional model together, and they were all defined, and we were working through the process, the contracts, last year, the hospitals that we're working with asked us, can we talk to each other? And we're going, oh yeah, we're working on summits. We're building summits to actually share best practices and evidence, both on the medical and the clinical and the administrative side. But they were talking to each other. They just initiated it. They've been talking to each other since probably last September. And they've learned so much from each other. It's been amazing. And this is the big one. The big one is if you can't and won't propose a bundle, you can be doing everything else well. We're not talking to you. When you're ready, let us know. And then the employer criteria, obviously they're self-funded. They have they're willing to do a significantly enhanced benefit. Actually, what we say, if you're not willing to pay 100% and pay all the travel, except for people on qualified CDHPs, because you can't, it's illegal. So we have to handle that differently, but otherwise they're all paying 100%, and they're looking for break even. They're not looking for discounts. They're all with the large carriers already. They're with Cross, they're with United, they're with Aetna, they're with Cigna. They're getting the best discounts in the country. That's not what they're looking for. They do want to not pay, they're just looking at break even. So we know what the costs are to travel people on average if they drive or if they fly. We know what our costs are. We know what the additional, get a pretty good handle on the additional benefit costs by doing 100%. Okay, we're looking at a little bit less, a little bit more, it just, but basically break even. And then one of the things we want to make sure before we start working with them is we're not making medical necessity determinations. If they're working with providers that they say, we think this is the best, one of the best heart surgery programs in the United States, why would we have us determine medical necessity? Our focus is around the benefit and authorization, and there are a lot of clinical components to that. It's amazing, some of the clinical components, but that's part of the model. So we just feel like bundling can facilitate quality. It creates greater predictability, transparency, and comparison across geographies. How many of you are in the provider world that you say, and I will tell you, 100% of medical centers that we talk to say that they're in the lowest 50% of costs in the region. What bundle does is take that away. I mean, we're looking at it, and we can compare across regions. But the other thing to realize, I mean, we're talking 1.2 million people on Walmart's plan, and we have 3 heart centers, 3 spine centers, and a transplant center. 1.2 million people, and that's all we need. We could do with less. So if you realize, and it was funny in talking to some of the providers, they said, wow, we're the lowest cost in town. Well, but think about this. You're in a high cost of living area. You're not competing with your fellow hospitals and physicians down around the town. You're competing with those folks in 5 to 10 states. That puts a whole nother spin on it. And really, it starts our folks thinking very differently. We believe that bundling allows true integration. I don't think there's a hospital in the United States at this point that doesn't have employed physicians. It's just the reality. We started with the clinic model, and we've still done the clinic model, but we do believe that that's the start. That's not integration. What Deidre was talking about, that's integration. So that's what we're looking for. And then one of the things I would caution folks on the payer side is too much of a good thing to become a negative. Be careful what you want to put in there. It might actually give you a higher price. So what everybody wants to know, what do you include in the bundle? Well, obviously standard pre-op evaluation. If we've got complex cases that needs more fee-for-service on the front end, we're willing to do that as long as it's demonstrated. Patient care per DRG, and I didn't put in here about readmissions. Predictable post-discharge. If you've got a surgery type that you know 90% of the patients go to rehab and have a week or 2 weeks or get home rehab or whatever, and you've got your protocols, that's what we want to see in there. We don't want you trying to take in all of the possible things that could happen because you're going to have to hedge your bets. I mean, everybody knows that. So, don't hedge your bets. We'll find a more reasonable way to take care of that. What we do not include that people ask about is we do not include travel costs, unpredictable rehab or aftercare. The outliers, we are looking at 5%. I mean, we've had hospitals give a proposal and we say, well, looks like you're having a pretty high number of outliers. What percentage are you looking for? Oh, 40%. No. That dog don't hunt, as one of my staff members says. We're really looking at equal to or less than 5%. So the benefit providers, I love this. If you're not doing it now, watch out. We may be flying your good patients 5 states over. And if we're not doing it today, we'll be doing it next year. The integration is just incredible. When you sit in meetings with the whole team, if the clinical people took off their lab coats and their scrubs, most of the time you wouldn't know who was clinical, care delivery, and who was administration. That's integration. And then think about what's the easiest thing to travel. We don't want, I mean, we have to have people that are safe to travel to do this, right? We don't want to be flying people and have them get lost at on the airplane on the way. So how does it create a foundation for true buyer-seller partnerships? It takes price per unit off the table. It reduces the incentive to do unnecessary care. Here's our results. Through the end of last month, with spine surgeries for Walmart, we thought we were going to see 30% of the cases are unnecessary and not going to get surgery. We're over 50%. The providers themselves are appalled at what they see going on. So, and this really helps us get there and get people focused on that. Provide true provider integration, quality improvement, creates predictability for the providers and the payers, as both. You know what you're going to get paid for a procedure. You can pretty much predict and budget for it, so can the employers. And then it allows comparison across medical centers and regions, and that's going to be, and already is, if you're not aware of it, your new competition. So, thank you.
So we've got about 15 minutes for questions. Any questions from anyone? Yes?
Is the Blue Cross Blue Shield Arkansas thing going to become a national program, or are you just going to do it in Arkansas?
Is this on? Okay. Right now it is just an Arkansas program. We do have some national employer group clients that have a lot of interest in having national programs. The issue is it's dependent upon individual states' kind of legislature and things like that on how the healthcare systems work in the individual states. We are part of the National Blue Cross Association, and so today and tomorrow the association is actually meeting to kind of talk about what national infrastructure does Blue Cross need to be able to support kind of let our people who live in Colorado benefit from whatever Colorado decides to do, and say employees of Lowe's that live in Arkansas to benefit from whatever Arkansas is doing. So we are trying to work on the infrastructure. Arkansas Blue Cross are independent licenses for each of those markets. So we are still individual payers that sometimes compete with one another, but we are trying to look at national infrastructure to be able to support it.
Do you think change came from providing more data to providers or best practices?
I think providing the data allowed providers to see that they were not actually doing the best practices they thought they were. We've got, like I said, we had those clinical advisory sessions a couple months ago for the cholecystectomy, or no, it was tonsillectomy is what it was. And so we had some ENTs from different parts of the state that practice at different facilities at the table. There are about 3 or 4 of them. And they were talking about the pathology. And one guy said, well, it's just my facility's practice. We send them all to the lab, go under microscope. And the other guy said, whoa, why are you doing that? If it looks funny to me, I send it, otherwise I toss it. And so there's some best practices out there, even within our own state, that there are guys who are upstanding surgeons that wasn't a part of their practice they paid attention to. And so I think it's made them all more aware of what they do compared to what everybody else does because they've never seen it before.
I think this is probably for Matt or Ruth. As you're working with employers or on the health plan side and you're identifying through this whole process procedures that don't need to happen, a lot of the people still have issues, put it mildly. how do you integrate, and this may be another whole seminar, but how do you integrate bundle payment with benefit design to provide alternative benefits to people that are cost effective, especially when you're paying 100% of the cost for surgery, but maybe somebody has a $2,500 deductible, but they need PT?
Yes, that is definitely an issue. We do a lot of work with the member. I mean, at some point, you just have to cut it off. You have to say, okay, this is it, and this is what goes back to the normal. We talk about wheels down to wheels up, because that's when we have them. It's a totally carved-out program. We work actually with Walmart, with Blues of Arkansas with Walmart, so we do those transitions. The transitions are really are very difficult. We are paying for other things and actually soliciting home physicians to get involved with the surgeons or whomever so that they have that transition, because when we were not doing that, we got lots of readmissions. And since we've really put heavy focus on that transition, and also with the carriers, our nurses on our team do a lot of work with the carriers' nurses to transition those cases over so that things don't fall between the cracks. But we found out the hard way. You have to do a lot of preparation with each member to say, here's where the benefit's 100%. This is where it's not. You're engaging in this program, understanding that from the very get-go. We actually build that into an authorization form that we use. So it's very difficult. Transitions are the hardest part of this. And I was telling some folks last night, we had a case of a 42-year-old woman who needed cardiac surgery and probably wasn't going to live much longer, a couple years. And we flew her to the clinic. They asked, we don't think she's a candidate, but two surgeons at home are saying she is. Can we take a look at her and see? And they said, no, you won't make it off the table. And so we sent her home. The surgeon that would have been doing the surgery made sure that they communicated with the home provider, who went ahead and did surgery, and she didn't make it off the table. And that's when you realize it all comes home, how important transitions are and how much we have to work with that.
I have a few questions. First of all, that was excellent. I really appreciated all the different perspectives. I guess I'll stand up since I'm short anyway. Matt, a question for you, or really any of you. There's a couple issues. One is, that we always talk about, physicians have the sicker patients or whatever. Is there some type of a risk adjustment built into your product so that you can, if there truly is a differential between the populations, that you can find that? So I'll ask that first.
Yes, in our models there is. Like in the perinatal episode, we've got around, I think it's up to 260 diagnostic categories that we review annually whenever we set our thresholds. And we basically assume any difference that exists on average in the state because of the presence of that is due to the condition and not due to practice. And so things like eclampsia or something, that every eclampsia case on average costs another $2,000 above the baseline. We subtract 200,000, whatever I said, we subtract that difference from what would be, like, to bring it back down to what would be a normal case. So it's all levelized, and you're only accountable for providing basically the core amount of care, and you have that buffer for the high-risk cases.
Gotcha. And then, Ruth, I think one of the things you talked about was the spine, and you say this 50% change in, the surgeries, and we all know that, from the evidence, wait 6 weeks unless you have red flags. There's certainly some guidelines out there, but in a program that was done here, there was certainly there was an opportunity that if you did have a patient that fell a bit outside of that, they were having significant pain, it just was relenting, but they didn't have necessarily the other red flags. Is there a way to make sure that we're not going to the managed care days that we're actually underserving and underutilizing, so that, are you using patient experience or SF-36, et cetera?
Yes, so actually, we were using, or some of the hospitals were using the SF-36, and we found that to be too long. So I think we went to the 12. I can't remember which version, but it's a smaller version. Because even in their regular population, they were getting less than they wanted people to even fill it out. So yes, we do that. And I think this is where the paradigm shift is. They're determiners of medical necessity. If they feel like somebody needs something, and actually for spines right now, we're actually building a couple new bundles. One for those cases where they think they're going to go to surgery, they bring them in, evaluate them, and then find out they don't need surgery and go home. So they can predict what they're going to get paid, and we're all reasonable. We're actually now building in a second opinion for spines because it's so unusual. And that's even with a company, the largest non-governmental employer in the United States, the number of cases are still, for these focused areas, are still much more manageable. And our watchword since day one in this company is flexibility, because we go on clinical evidence, not just dollars and cents. So yes, and every time we do somebody new or a new procedure or a new medical center, we learn lots of new things that allows us to be adaptive. And that's where the partnership is. And that's really critical.
I think what I would just add is the flex. We definitely see with commercial and employers a lot more room for flexibility and design. My worry with the Medicare and some of the public payers is I don't think they've adequately risk adjusted, and there's not a lot of flexibility there. So that's where I think if you're going to test this, employers and commercial payers are much more open to, your input in design where you don't really have that with public payers.
Right.
I have a quick question for Ruth. Thank you so much for the presentation. I was wondering if you had any thoughts. I'm an emergency physician here at this facility, the Academic Medical Center, and what are your thoughts on the future of academic medical centers that cost more, train residents, have trauma centers, and have super specialized care? I think there's a lot of anxiety around the payment reform that it will basically move much of the business out of academic medical centers because of the cost.
I think that concern is well-founded. I hate to say that. I wish I weren't saying that. One of the things that we're starting to do with some of the employers is, particularly with the regional model, is having regional centers that do the less complex, and then some of the academic medical centers to do the really highly complex stuff. So we're starting to separate some of that. As we're looking at cancer, which we're working on now, we're looking at, it's going to be, you want to talk about a focus factory, we're actually going to do an equal number of academic and non-academic cancer centers, and we'll see what comes out. I mean, some of this is we're just all learning. We're making this up a little bit while we're going along, but trying to do it on good principles. And I share your concern. I mean, somebody's got to pay for medical education.
The one thing, though, we see with the UC system is doing some interesting work in terms of partnership where the physicians are going to other, ancillary sites. We see that with Vanderbilt as well. So I envision sort of the traditional just being, at home base, probably not likely going to happen in the future. What the UC system is doing is they're contracting with community hospitals and they're sending their subspecialists to a broader region.
Yeah, we're starting down that path too, so yes, good point.
I have a question for the whole panel. How do you measure quality in your programs?
Go ahead.
The approach we've taken, whenever we have an episode and we have the meetings with our clinical advisors, we'll do literature review, determine are there kind of best practice guidelines of what you expect to see. Like for perinatal, we've got those screenings that we require to be performed. And we basically just have interviews with the people who are providing these services and say, what are things that need to be done every single time or 75% of the time? So we'll actually kind of vet within our own delivery system in Arkansas what our kind of champions feel the quality should be, and then we cross-reference that to literature review.
I think I would just add there's so much that's not in the literature, and so I think that's where, bringing multidisciplinary teams together to really begin discourse and really look even beyond your area and your region, because so much of what we do, isn't, there's no evidence for, right?
Yeah, well, and there are, the state-of-the-art of outcome measures is not real advanced at this point, and some of the colleges are, I mean, STS has a pretty advanced system for cardiothoracic, and some do and some don't. So we're working with our medical director and the medical director at some of the companies. We're also, most importantly, working with the providers we're contracting with, and we're saying, here's a baseline, this is what we're looking at. But we already know you guys are good here. We wouldn't be talking to you if you weren't. And we're really, that's a big part of the summits that we're putting together is how do we define the metrics that we really want to continue to monitor that are really above the baseline.
Thank you for those really useful presentations. I learned a lot about the mechanics of operationalizing bundled payments. My question is more on the result side, specifically the financial results. So, Matt, you mentioned, I think if I understood it correctly, that 4 out of 5 providers were in the gain sharing column, so indicating that they're moving in the right direction. But can you help me wrap my head around how much we're talking about in dollar terms? Whether it's percentage-wise, return on investment, I don't know, just help me quantify what this could potentially mean in terms of savings or costs avoided.
I don't necessarily have all the numbers off the top of my head. And basically, my statement earlier was whenever we kind of set out initially with our thresholds on the historical data is we looked for revenue neutral, meaning our risk share equated to the gain share. As we got closer and the providers actually saw the report and we looked at it again, we're actually seeing that if we're paying out or if we're bringing back $10,000 in the risk share, we're actually paying out $40,000 in the gain share. So it's not necessarily 4 out of 5 providers are in the gain share, but the ratio of gain sharing to risk sharing has gone to 4 to 1. Overall, we're not exactly sure what we expect to see on the return on investment, to be quite honest. There are a lot of changes going on, and we're kind of focused on just some specific services. Ideally, we could see, since we kind of set that 85th percentile for that acceptable amount, if we can bring all of that down, then we've just saved all that excess above that 85th percentile. So we will be able to measure return on investment, but we're still a year away from it to really see what it's going to be. We're hoping that it's significant.
I think I would just add Medicare with ACE. I think year one saw an average of about 5% savings on the hospital side. I think for us with physicians, if they didn't see a gain share of at least 7 to 10%, oftentimes they felt like there wasn't enough in it for them. So I think you do have to be careful and make sure that the financial incentive is, not the $12 check from the HMO days. If you're going to have physicians really do meaningful work, but I think CMS is looking for estimating about 5% savings.
And from Arkansas, from the payer perspective on return on investment, our Medicaid agency, and we're seeing similar things on our private side, is annual increases of 6% on overall spend. If we can get that down to 2% of an increase, so it's not really a return on investment year over year as much as difference from projection. And so we're just trying to bend the curve a little flatter than it has been.
I think we have time to sneak in one more question up top.
Ruth, you talked about appropriateness and indications for the bundled surgeries that are done. I'm wondering if in Arkansas or St. Joe's, you're looking at the appropriateness or indications for surgery also.
Oh, yeah, definitely. And actually, in our contracts, it says that the responsibility of the provider is to determine medical necessity, but we always reserve the right to review any case that we feel. I will tell you, our nurses have worked so closely with the providers. They're just very much aligned in even cases where we thought, well, we can go either way on this. we're really finding a lot of alignment on that. And we are monitoring those cases. We do concurrent review because we're going to be managing aftercare. We're looking at claims appropriateness and lots of other things. So we're monitoring that as the case goes through, as if we were doing medical necessity. But we reserve the right, and I would say maybe once or twice in the last couple of years, we've had to execute that.
I think for us with ACE, there were probably 2 patients we would have done if we had not been in the ACE project. One was a Jehovah's Witness, and another was about a 90-year-old patient that her family wanted her to have the surgery. What I did see pretty quickly out of the gate was our physicians much more committed to, having discussion around risk score and, how to manage family expectations and some of the social aspects of this.
Yeah, I would agree. Managing the patient and family is a major issue, and it's both clinical and non-clinical. We found that we needed to add a new role of, our nurses have always been patient advocates. That's how I started the company, and as long as I'm kicking, it's going to be that way. But we found we had to institute a member advocate role that is significantly higher than customer service. It's not customer service folks. It's someone who works very directly, who is not clinical, because there's so many non-clinical parts to this program that they need support on too.
I really anticipate we're going to have a product where if the patient doesn't meet the risk criteria and they still want it, then they're going to be paying for it, right?
We've had some clients talk about that.
Yeah.
Nobody's instituted yet.
Sorry. Arkansas, are you doing anything with the appropriateness for surgery?
Under our current episode model, to kind of get buy-in from the provider community, we didn't want to impose kind of medical necessity edits on the front end or pre-authorization for them. So we basically just run under the assumption of if an episode is triggered by that accountable provider, that it is appropriate. And then we'll measure the episode after that. We will be monitoring program effectiveness and program integrity to say, okay, do we have guys that have really bumped their knee and hip replacements when they weren't really necessary to try to game the system, really get their volumes up. We are going to monitor them. We've got pretty close relationships with our providers in the state, being as small as we are. So we were on a first name basis with most of our providers anyway, so they know we're watching them. But that is something we're considering, and that's another aspect of like the patient-centered medical home model that we're trying to figure out in Arkansas too, is once the general practitioner or that clinic is accountable for the total cost of care in a way, then some of the medical necessity questions can get answered along that path. Once they can start seeing where their patients are going, what procedures are being performed, and what levels of care are being done.
Thank you.
You said something that is really critical around this. When patients don't need surgery, they're sent home with a treatment plan. When they do need surgery, I mean, I can remember taking a look at some of the medical histories on some of the folks for Lowe's very early on, and I just said we have to build something to address both of these issues, because if you're a 300-pound diabetic, type 1 diabetic that smokes, you're going to have heart disease. And what we saw is we're dealing with the procedure and the surgery, and all these employers have multiple tools, wellness, disease management, whatever. So we're working towards creating a program that even if the person does have surgery, that we can coordinate with the other vendors that they're using, because if they don't do something about the lifestyle, and that's where I think the tie-in with medical home, and I'm so glad you said that, Matt, because that is so critical. If we can get somebody into a medical home based on a whole nother vendor, but we're getting the patient to the right place, it's really important.
Thank you.
A couple of housekeeping things here. That was fantastic. Really appreciate that. So Civic's role in this, we're a facilitator. My goal coming out of this, and the entire staff's goal, is that we can get a dialogue going between the key players in the audience to start talking about bundles. One of the key things that Civic can provide is data. I think you heard across the board that the first step to evaluating a bundled product is to have data. We have 1 million commercial lives in our database currently, and we are more than willing to start working with you to try to provide some of the data to begin this process. And my information is up there. If you're interested, we are more than willing to help you facilitate the process of getting a bundle going. The slide presentations are all available online on our website. Deirdre's are not, but if you would like a copy of her slides, just put your card in the evaluation box that's out at the registration desk. Please fill out your evaluations. And I want to thank the panelists again for a wonderful presentation. And everybody have a safe drive and great rest of the day.
Thank you for being a good time keeper. You were wonderful.
Hi, it's good to see you again. Yeah.
I'm Army.